A very good afternoon to everyone. I, Dr. Sandha Meshram, I extend a warm welcome to all the esteemed faculty, dignitaries, and the delegates on behalf of Team POGS for this yet another webinar in the Cutting Edge series. Cutting Edge webinar series is a brainchild of Dr. Meenu Agarwal, our immediate past president POGS, Dr. Vaishali Chavan, and Dr. Charulata Bapai, which has been actually continued in this term as well. So let's start our today's webinar. Today's webinar is in association with Indore OBGYN Society and Nagpur OBGYN Society. So I request Dr. Aarti Nimkar ma'am, our President POGS, to give a welcome address to all the guests and dignitaries.
Good afternoon, everybody. I am Dr. Aarti Nimkar. Welcome you all for this cutting edge webinar. This is a very good program started by Meenu, and because of this, we all societies from the distant places also can meet and discuss the different topics in this webinar. So it is a very well appreciated webinar. So I welcome you all the chief guest, Madam Lakshmi Madam, chief guest of honor, Sonia Madam, and Jyoti Madam, and all the faculties and chairpersons. And we will start the webinar immediately.
Thank you, ma'am, for your kind words. I request Dr. Meenu Agarwal, ma'am, to say a few words.
Yes, thank you, Sandhya. Thank you, Aarti Madam, for continuing, because we started this in my tenure, this cutting edge webinars, and thank you for taking it forward from there.
Hello, Dr. Neelam.
I'm very happy that this time we are joining with two very big societies and very popular societies in Foxy.
Yeah, Dr. Neelam, are you with me?
Lakshmi ma'am is joined.
Yes, madam, we are with
Basically,
you.
all of us are kind of united by a common thread called Foxy. So we are all sub-committees, sub-members of Foxy. We are all together in that term.
So Dr. Neelam, we can see you. नहीं सुनाई नहीं आ रहे हो आप, सुनाई नहीं आ रहे हो
मैडम आप
नहीं I called her, she is thought कि we can hear her, but we are not able to hear her.
लक्ष्मी मैडम का ऑडियो ऑन है.
So we are very happy to have Dr. Lakshmi Shrikhande as our chief guest today for this webinar. And we have Dr. Sonia Malik and Dr. Jyoti Banglowala. So all three of them are very esteemed, very eminent in their fields, and they will be giving us their blessings. We also have Nagpur Society President and Chairperson Dr. Sandeep Nikhare and Dr. Ruchita Fuke. So
Dr. Anju, you can take a call because she is having, I think, some network issue now. She is logged out.
Indore OBGYN Society, which is very close to my heart again. Dr. Sadhana is here and Dr. Shweta Kaul is here. So very warm welcome from POGS, Pune OBGYN Society, as well as from us, myself, Vaishali, Charu, we are all, Dr. Sandhya, Meenakshi, and Aarti. So all of us, thank you very much, and Amol. So we welcome you all, and Sandhya, we can take it forward from here.
Thank you, ma'am, for your kind words. Can I request Mr. Prasad to please start the prayer so that we can have a short prayer before introduction?
आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Now I welcome Dr. Vaishali Chavan ma'am to please introduce our chief guest.
Thank you, Sandhya. And before I do the introduction, I would like to once again welcome all the dignitaries present here and all the delegates who have logged in for this very unique and remarkable cutting edge webinar. And today POGS in association with Indore and Nagpur OBGYN Society. And this is at this forum, we would also like to declare about Dr. Meenu Agarwal, who is standing for the post of Vice President Foxy West Zone. And we solicit everybody's support because she is the most capable and she is the most deserving, as you will later on hear to her speak also. She is highly academic and very well known for this. So a very warm welcome to everybody. Chief guest, Dr. Lakshmi Shikhande, guest of honor, Dr. Sonia, Dr. Jyoti, from Nagpur, Dr. Sandeep, Dr. Rujita, Dr. Sandhya Mehta, Madam, Dr. Sumitra Yadav, Madam, Dr. Shweta Kaul, and everybody who's present here. So it is a proud privilege for me to welcome Dr. Lakshmi Shikhande. Mr. Prasad, can you show Madam's CV? As we know, Madam is a very, very dynamic leader, and she has just finished her post as ICOG chair, and where she did revolutionary work and took ICOG to greater heights. She is also National Corresponding Editor of Journal of Jogi, National Corresponding Secretary, AMWI, in Association of Medical Women India, President ISOPAP Vidarbha Chapter 2019-21, Chairperson IMS Education Committee 2001 and 223, Chairperson Fertility Enhancement Committee, ISOPAP, member of CEPFOG, President Association of Medical Women Nagpur 2021-24. She was Senior Vice President Foxy in 2011. She was President of Nagpur OBGYN Society, President of Menopause Society Nagpur. So many posts Madam has already headed. And she's also Medical Director, Shikhande Fertility Clinic, Nagpur, Maharashtra. And Madam has received many awards. To name a few, like Nagpur Ratan Award and Bharat Excellence Award by Women's Health. She has delivered more than 22 orations. She's a prolific speaker and an orator with more than 450 guest lectures, many publications, international as well as national. And she's done a huge amount of work in adolescent health. So I request Madam to give us her blessings and say a few words.
Thank you so much.
Yes, Lakshmi Madam, I remember in one of the Foxy meetings, you had given all of us pedas because Madam's son in NEET examination, he topped for the PG NEET examination.
Yes.
So, and he then chose to take gynec in Nagpur. I remember that much. And then after that, I don't know. He must have already cleared and become a gynecologist. So very nice, Madam. Yes, I still remember that. Very big thing to be topping the NEET exam.
Yes. Thank you, Vaishali, for your kind introduction. And thank you, Meenu. You definitely have a very fantastic memory, I must. And I'm so happy to see the immediate past president of Pune Society, Meenu, Vaishali, and current president secretary, I can see Dr. Aarti, Dr. Meenakshi, and what to say, my own society, Sandeep is here, Rujita is here, and this is along with Indore also. So I am so happy to meet the Indore OBGYN Society president, Sadhna, Sumitra, Shweta. So happy. And I am really happy that you have written hysteroscopy, basic to advanced, everyone can do. Meenu, I don't know advanced where everyone can do, but basic, yes. I always tell in my presentations, wherever I speak on hysteroscopy, that when all the urologists, they are doing office hysteroscopy, they just can't think of doing their practice without office hysteroscopy. So why we gynecologists cannot do hysteroscopy? I mean, at least basic diagnostic office, because it is really the learning curve is just 3 to 4 hysteroscopies and everyone can do, I believe, office hysteroscopy, diagnostic hysteroscopy. And I am so happy that Meenu will be guiding and Sandeep, who is himself a great endoscopic surgeon, will be giving his expert comments. Advanced does need, I mean, it has a learning curve and you really need to have a good infrastructure and your staff. But yes, basic, everyone can do. Then intrapartum care. Yes, I know antepartum is very important, but intrapartum is like a climax, you are handing over the baby to the couple, and that is the wow moment that they are actually becoming the parent, the mother and the father. And you have to avoid so many problems in this era of medical legal litigations on the rise. I know intrapartum care, each and every obstetrician has to be extra vigilant. So I'm sure the speaker will be doing and telling you all the practical tips, and happy once again to be part of your cutting edge webinar, Meenu. Wish you all the very best, not only for this webinar. I know you are contesting. I wish you all the very best for all your future endeavors. So thank you for having me here. Wish you once again all the very best. Thank you.
Thank you. Thank you very much. Thank you very much.
Now I call upon Dr. Meenakshi Deshpande, General Secretary POGS, to please introduce our chief guest, our guest of honor, Dr. Jyoti Banglowala.
Hello, am I audible? Yeah, thank you, Dr. Sandhya. On behalf of POGS, I would like to welcome all the faculties and the chairpersons, and also our dear Meenu, because she is taking this cutting edge webinar diligently every Tuesday. And that is a feat, accomplished this year, because we are having some program every Tuesday. We remember that. And yes, this is adding colors to our POGS also activities. So we would really like it to continue. And yeah, it is basically a good thing that I'm got this opportunity to introduce Dr. Jyoti Banglowala. Can I get the slide, please? Yeah. Because I am also a medical legal person. I'm doing my third year LLB, and I would like to introduce Dr. Jyoti Banglowala here. Welcome, Dr. Jyoti Banglowala, madam, who is a chairperson of Ethics and Medical Legal Committee of FOGSI. She's got 28 years of experience as a medical legal advisor. She's the vice president of Indore Obs-Gynae Society presently, and a secretary of Indore Obs-Gynae Society in 21-22. She was a treasurer of IOGS, and I am a representative for the MTP committee Indore. She is a coordinator of medical legal workshop NAGOCON Indore, treasurer of AICOG 2022 Indore, and she is a recipient of many awards, recipient of MS Signature Award, recipient of Wonder Foxian Award, recipient of Indore IMA Corona Warrior Award by MP government, then recipient of the Nari Shakti Award, IMA Indore branch, Corona Warrior Award again on 15th August, recipient of the Dhira Award in September 2022. And she has published many papers, conducted various educational awareness campaigns. She is an invited faculty in many national and international conferences. So welcome, madam, to our with this POGS webinar, cutting edge webinar, and I welcome you to say a few words.
Thank you, Dr. Meenakshi, and good evening, everyone. And it is I'm happy to see this new Aarti madam and Meenakshi madam taking forward the previous year's president and secretary's work. It is so heartening to see, because this cutting edge webinar is something very good when we were watching this last year. And Aarti madam and Meenakshi madam, they taking forward, it is a really nice gesture. And thank you, Meenu, Vaishali, Charu, and Amol for giving me the honor of being guest in your vibrant society. And today, this topic of what Meenu is taking, the office hysteroscopy, I just request you just to tell about the type B and type C category of society, when to do, when not to do. Because just buying the instrument is not the enough thing. Just going to the conferences and buying the instruments and just start doing in the manner of the newly learned. There are so many litigations coming around this office hysteroscopy also. So we are watching you, Meenu, giving the insight of this subject. And our own Dr. Sadhna madam, she is so soft-spoken, she is so good. She is the best person to give this topic, the intrapartum care. And our own chairpersons, Sandeep sir, Rujuta, Dr. Shweta, Dr. Sumitra, the very apt person you have taken for the chairperson. And thank you, Rujuta, for this You have met me the last time Dr. Sandeep made me and asking for this conference in the Nagpur. So thank you for the invite also. And Dr. Meshram, thank you for all the connections you are giving for this webinar. And Meenu, you are contesting for the post of Vice President. And as you know, I am telling you since so many years, you are getting late, Meenu, go. You are the apt person to go for the Vice President. So best of luck for you from my society, from me, from all of us are says. Best luck, Meenu.
Thank you so much, Jyoti, for this kind, very sweet message. Very, very nice. And I can see also Dr. Sonia Malik, Madam.
Yes, Sonia. Good evening, Sonia, Madam.
Yes.
evening, Sonia.
Yes. So, Jyoti, you're always very soft spoken, very polite, very smiling, nice. So, it's always a pleasure to connect with you anywhere, foxy, non-foxy, and anywhere. It's a pleasure to connect with you.
Thank you.
So, thank you so much for your wishes. And Sonia, Madam, thank you for joining. I know you were not able to log in for some time. Hello, Sonia, Madam.
Sonia, Madam, please unmute yourself. Sonia, ma'am. Dr. Sonia and Dr. Sumitra Yadav also joined. Dr. Sumitra Yadav is the president-elect of Indore Society.
That's right. Yes.
Welcome, Dr. Sumitra.
Hi, yes, I have joined. Thank you very much. I became late. I was involved in an emergency.
Oh, yes.
So,
Sonia, Madam, ko introduce kaun kare?
Ma'am, I request Dr. Vaishali ma'am to introduce Sonia ma'am and give a formal introduction and welcome.
It's an honor and privilege to welcome and give an informal introduction for Dr. Sonia Malik, who we know is a big name in infertility, a living legend. And Madam right now is Chief Clinical Mentor, Pan Nova IVF Group at New Delhi. And she has a Chair Advocacy Committee, IFS 2018. And till date, she's also past chair Infertility Committee FOXI 2014-16, past president Indian Infertility Society 2014-16, past president Indian Menopause Society 2007-8, chair of Infertility Committee AOGD 2011-13. Many posts Madam has held. She's also associate editor SCE Asia, Journal of Global Health IFFS. And she has been teaching and training all the young generation. And she's been teaching at IFS Fellowships in Reproductive Medicine and Embryology, ICOG Certificate Course in Reproductive Medicine, and SFIC Fellowship in Reproductive Medicine and Embryology. She has published many guidelines, especially ones on PCOS management in India. She has authored 2 books in infertility. And Madam has received many...
Enough. I think that's enough. Let's stop.
Madam is
That's enough. Thank you so much. Thank you so much. Thank you very much for having me here.
Sonia Madam is an encyclopedia on infertility. She is a mentor not only to so many students all over India, especially in Delhi, but all over India. So, and you listen to her lectures, especially the lecture on your ART law. That was mind-boggling lecture, one of the best lectures that I have heard on ART law, Madam. So, thank you for joining and welcome, Madam. Thank you.
Thank you so much, and thank you so much, Meenu. I don't deserve what you have said, but anyway, I think you all respect me for keeping my gray hair and my age in mind. So thank you very much for giving me that respect. I'm so grateful to all of you, and I would love to hear what is going to be said about hysteroscopy over here. I'm waiting for Meenu's lecture. Another wonderful person who has always been, like Jyoti mentioned, always been behind yet in front. We cannot not miss her, because basically, even though she's quiet, she's there. So with all that, I think I shouldn't waste your time. Let us begin with the webinar now. I can see some wonderful juniors over here. Amol is here, Shweta Kaul is here, Sandeep is here, and of course Vaishali spoke just now. So please carry on. Please carry on.
Thank you, Madam. Thank you. Thank you for your kind.
Good evening, Madam. Good evening. Thank you.
Good evening. Good evening.
With this, we start with the first session, and for that, I call upon Dr. Amol Lunkada, Clinical Secretary POGS, and Dr. Meenakshi Deshpande, General Secretary POGS, to please introduce the chairpersons for the first session. I request Dr. Amol to introduce the chairperson, Sandeep sir.
Yeah, good evening all. At the outset, let me thank the Nagpur Obs-Gynae Society and Indore Obs-Gynae Society for associating with Pune Society for this webinar. And let us start with our first lecture. It's my proud privilege to introduce to you the chairpersons for this first session. Dr. Sandeep Nikhade is the president of Nagpur Obs-Gynae Society, director of Lifespring Hospital and Parvati IVF, director of Milestone Hospital and Endoscopic Foxy Endoscopic Committee. Is invited member for Foxy Membership Cell, one Foxy's Dr. C.S. Don Award at AICOG Kolkata 2023. Is the winner of IAG Annual Conference Endoscopy Video Award 2021. Winner of Dr. M. Rothgi Award for Endoscopy in 2020. Organizing Secretary of IAG Gynecology and Laparoscopy Live Workshop 2016 and 2022. Has performed more than 15,000 laparoscopic procedures. So thank you, sir, and it's a privilege to have you. The second chairperson, I think Dr. Meenakshi.
I request Dr. Meenakshi Deshpande to introduce Dr. Rujita.
Yeah, welcome, Dr. Can we get a slide of Dr. Rujita Phuke? Yes. Welcome, Dr. Rujita Phuke, as a chairperson of this session. And I would like to also welcome other faculties from Indore and Nagpur. Dr. Rujita Phuke is Associate Professor, Department of Obs-Gynae, GMCH Nagpur. She is an undergraduate and postgraduate faculty of MUHS Nashik, and she is routinely invited to serve on the examiner panel for OBGYN examination of various universities. She runs a cervical cancer screening and colposcopy clinic at Department of OBGYN, GMC Nagpur. She's trained in colposcopy at Calcutta. She's trained in fetal medicine at Bangalore. And she's a fellow of Indian College of Obstetrics Gynecology and Indian College of Maternal and Child Health. In her achievements list, she has got the late Dr. Rangilal Singh Memorial Award, late Dr. Sundarabai Kunnawar Memorial Award, Dhanvantri Award, late Srimati Shakuntala Suryavamshi Memorial Award, the Pfizer Gold Medal for Excellence in Undergraduate Studies. She's also delivered the prestigious Yuva NOGS Oration in 2015. She's the editor-in-chief of a book on menopause and contributed a chapter in 4 books of OBGYN. In her presentation, she's presented an original research article, publication 9 as a first author and 1 as a second author in international journals. She is a faculty at local, regional, national conferences and presentations at international conferences at Sri Lanka, Singapore, and Prague. She's worked as a nodal officer for facility-based maternal mortality review committee for 5 years. And she's a peer reviewer for journals of OBGYN. So I welcome Dr. Rujita Phuke as a chairperson.
Thank you, ma'am. Thank you. Thank you so much, ma'am, for the kind introduction. Good evening, everyone. Good evening, respected faculties, for today's webinar. So shall we move ahead?
Thank you. Yeah, thank you, ma'am. So I request Dr. Sandeep sir to please introduce Meenu madam for her talk.
Dr. Sandeep, you can.
Hello, Dr. Sandhya.
Yes, sir. Yes, sir. Please, can you please introduce Meenu madam for her talk formally once, so that we can talk. We can start with the talk.
So welcome everyone, and thank you for getting joined us today. Today I am excited to introduce a gynecologist with extensive experience in hysteroscopic procedures. She is known for her gentle touch and compassionate care during hysteroscopic procedures. She is recognized as a leader in the field of hysteroscopy, and that's why she was awarded India's Greatest Leaders Award. She was also known for the Champions of Foxy Award also. So, as we are getting late, let us start and hear from the master herself the hysteroscopy from the basic to advanced. Everyone can do it.
Thank you, Dr. Sandeep. Thank you for your kind introduction. And I also here welcome Dr. Sumitra Yadav here. She's here. She's the head of the Department of OBGYN at Indore Medical College and Vice President of Indore Society. So welcome, madam. And
thank you very much, madam. Thank you very much. It is my proud privilege to be a part of your webinar. Thank you, madam.
Thank you. Thank you. So, good evening, everyone. And I shall be talking about hysteroscopy. You know, both diagnostic hysteroscopy, see and treat, that will be diagnostic, and minor operative hysteroscopy, and then operative hysteroscopy, where we have already planned a surgery for the patient hysteroscopically, and we take the patient into the OT. So when we talk about the types of hysteroscopy, office hysteroscopy, again, there is nothing like a diagnostic hysteroscopy anymore, because office hysteroscopy can be diagnostic, and if you find some pathology, you will treat it at the same time. That hysteroscopy. And then we have an operative hysteroscopy under anesthesia. So these are the two categories that we are using. When we little bit look at the history of hysteroscopy, actually hysteroscopy came into picture much before laparoscopy. But laparoscopy took over and hysteroscopy lagged behind. There were multiple reasons behind this. Of course, there were general surgeons, there were urologists, there were veterinary surgeons who were trying to take laparoscopy to another level. But the main problem with hysteroscopy was there was no distension systems that we had. So the moment we would enter into the uterine cavity, we would not see anything, get frustrated and come out. Even today, I do get calls or do get my, some juniors telling me, madam, अंदर तो चले जाते पर दिखता कुछ नहीं है अंदर जाकर के. हमको ऑस्टिया ही नहीं दिखता है अच्छे से, आप कैसे दिखाते हो वैसा नहीं दिखता है. तो थोड़ा सा वो डिस्टेंशन जो है, that is a very, very important thing that we have to keep in mind. So once we had the distension systems and we could do hysteroscopy in 1980s, it became kind of a gold standard for intrauterine pathologies. However, sometimes for a diagnostic hysteroscopy, आपने patient को OT में लिया, anesthesia दिया, one day the patient has to pay everything, all of that. And you go in and it was normal and you come out. So it was just a 5 minutes procedure for which all this was required. For Western countries, there was a problem with the manpower. For countries like us, we did not have so much with the manpower, but we have financial constraints, which is why the hysteroscopy again was not moving forward. Then, of course, came the era of modern hysteroscopy, where the diameter of the hysteroscope from 5 millimeter, 4 millimeters, 2.92 millimeters, and even 1 millimeter. So the size went on becoming smaller, and it then became more and more of an office procedure. We also understand that when a lady is getting her menstrual cycle, the whole of the endometrium is shed off, but she does not get any pain. So the nerves are coursing along with the vessels. So if we do minor procedures on the endometrium, she will not get any pain because there are no nerve fibers there at the superficial layer of the endometrium. Why does she get a pain when we do an office procedure? Is because of the distension. So we have to keep in mind that the distension pressures have to be kept to an optimal level for her not to feel uncomfortable. But if she has a small adhesion band, if she has a small endometrial polyp, that can be done very comfortably and she will not get any pain while that procedure. Another thing, whenever we are doing an office procedure, we should understand that we should not be touching anywhere when we are entering. So try and go inside just like a tunnel, like the train is entering into the tunnel, not touching the walls. And this was, of course, first described by Betoki. I remember watching him in 2005 or 6. He had come to Jodhpur to do a workshop, and he said, I don't need a speculum, I don't need a tenaculum. And I said, how is he going to go inside without a speculum and a tenaculum? So this is a good vaginoscopic approach that he developed. And this is, again, another thing which we should understand is, just excuse me, hello? थोड़ा सा Yeah, I'm sorry. So that is very important that when we are entering into the cervical canal, we are not touching the walls of the cervix and we are going inside just like a tunnel. So another thing is that when we are taking an instrument inside, the instrument is parallel to the scope. Okay, so it is not like a laparoscopy that we have a manipulation angle. There is no angle between the scope and the instrument. So how we have to work is just the scope is going in and the instrument is going in. So I will just tell small tips and tricks how to cut a septum, how to cut a small polyp by just moving the scope and the instrument in a parallel way. What in our mind we think that when we are seeing, we are taking the instrument inside and it is forming an angle with the scope and we can cut it. And that is where there is a bit of hand-eye coordination which can have a problem. So now we can go with a vaginoscopic approach. We first go into the vagina, wait there, let it fill up. Take a mop and you can just keep it on the vulva so that the water is not leaking out and it fills up faster. Then the cervix is seen, it's a different kind of a tissue than the vaginal tissue. Okay. So the moment we see cervix, then you look at the external os, and once you see the external os, just follow. One very, very important thing while doing an office hysteroscopy is never keep the os in the center, because it is a 30-degree scope. So if you keep the scope in the center and go, in the opening in the center, you will be hitting the wall of the cervix. So always keep the cervix, the opening, what you see, at an eccentric position. So it could be posterior, it could be anterior, right lateral or left lateral, depending on the position of the uterus. So that is a very important point that we should keep in mind. And so when you look at this now, this is an oval shape here. When we look at the internal os is not round. It is oval shape. So I think Betoki is more of a scientist, and he realized that internal os is, if we put a round scope in an oval opening, patient will get pain. So that is why the newer scopes are all oval in shape. So, but you have to negotiate. The oval should go into oval opening. So that negotiation with the right hand is very important. So always keep your scope in the non-dominant hand and your light source in your dominant hand, so that you can negotiate the diameter of the oval shape of the scope into the oval shape internal os diameter. Now, when you look here, you see there are these 5 holes over here. You see there is one hole over here. Okay. Now, this hole is attached to the inflow. All right. And these smaller holes are attached to the outflow. So inflow is coming from here and it is filling the cavity. So it is coming at the tip and it is filling the cavity. And the fluid which is getting collected is going through these small holes. Now, if you make a mistake, अगर नर्स ने इनफ्लो को आउटफ्लो में लगा दिया, आउटफ्लो को इनफ्लो में लगा दिया, then what will happen? The water is getting filled up from here, it is getting evacuated from here, and you will not get any distension. Because नीचे पानी आ रहा है, ऊपर से जा रहा है, तो ऊपर we want the distension to happen. So this is very, very important point, that we must understand the physics of every instrument and instrumentation before we use it. Also, when we, as I said that when you look at here, See, this is the light source here. So when our light source is posterior, what we are looking is the anterior part. When your light source is anterior, we are looking at the posterior wall. So we don't need to move the scope at all. We are inside the uterine cavity. We just move the light source up and down, and we can take 12 times. We should take the sighting inside the uterine cavity, at the fundus, at the mid cavity, and at the level of the isthmus. Especially when you have something like a isthmocele, very beautifully you can see on hysteroscopy. Again, as I said, this is where the light, when the light source is posterior, you see the anterior, and you just move the light source and you can actually scan the entire uterine cavity. Now, again, why we need 30-degree scope? Why not a 0-degree scope, or why not a 12-degree scope? Because when we are using a 30-degree scope, you move the light source, you can see right and left. We don't have to move the scope at all. However, had it been a 0-degree scope, what would have happened? You would have to move the scope right or left. You see here, left and right, you have to move the scope, and the patient would get pain, especially in a office hysteroscopy. Where would we use a 12-degree or a 0-degree? This, if you have an option, those are the hysteroscope that you can use for a septum resection, that is, or anything you want to do in the mid cavity, that is where you can use a 0-degree or a 12-degree scope if you have the availability. Now, when you are inside the cavity, again, it's important for us to know whether we are dealing with a polyp. So whenever we find thickened endometrium, what we do is something called saline hysterography kind of a thing. We push in a little normal saline inside the uterine cavity, do an ultrasound, and here we can see a nice polyp sitting over here. Now, when I said that you have to keep the os, the opening always at an eccentric, this is what I mean. This is the opening here. This is eccentric, not in the center. If you keep it in the center, you will not enter. So always keep it just a clock, ghadi, uske charo taraf, there only you keep the opening when you are entering into the, see, this is posterior, because you keep it eccentric and then you enter, and then you can enter without touching the walls of the cervix, and patient will not have any pain. Again, small uterine synecdoche, we can suppose internal os tak pahunche and we cannot go inside further ahead. We have few options. You can either put a scissors, cut the adhesion band. Only thing is possibility of a false passage is much more if you use scissors. So now most of us, I'm sure Dr. Sandeep will agree with me, that we put in a grasper, we just open the grasper in anterior-posterior and in left to right, just widen the opening and then follow the hysteroscope into that opening. So this really works pretty well, especially when you have, some kind of adhesions, patient has amenorrhea, post DNA or something, and you are not able to enter into the cavity. So under vision, it really helps, and then you can very beautifully then go under vision inside the cavity, and if there is any pathology inside the cavity, that can be taken care of again as an office procedure itself. Sometimes you can see thick synecdoche. It looks like a septum, but there are thick synecdoche inside the uterine cavity. Again, it is an office procedure. And sometimes once you have done an office procedure, you feel, no, this patient requires a little more than an office thing. Then you can always come out, take the patient under anesthesia and do it in the next sitting. So what all can we do as an operative procedure? Suppose you find a small endometrial polyp sitting here, then these can be either done with a monopolar, bipolar needle or with a simple scissors. A small tip again, whenever you are using scissors on the lateral wall, use with one blade moving and one blade fixed. So fix your blade and then move the scissors. Another thing is, when you are taking your instrument inside, open your instrument and don't move your instrument inside. It is parallel to the scope. Open your instrument, move the scope with the instrument, and then cut the tissue. Again, come out, move the scope with the tissue and cut. So you don't move the instrument alone. Move it with the scope and come out. You will find your perforation, your complication rates will go down, and you'll find it much easier to do as compared to when you're actually moving only the instrument. Again, this is a small septum along with polyp in both the ostia. On an office hysteroscopy, she seemed to have a normal ultrasound findings, but with just a thickened endometrium at the fundus. Like Dr. Lakshmi said that, you have to be very, very careful when we are doing an operative hysteroscopy. Don't take it lightly. If fibroid I have done 3 or whatever number of diagnostic, I can do a fibroid hysteroscopic myomectomy. Be very, very careful when you're doing a hysteroscopic myomectomy. Number 1, do a good mapping of the fibroid. Kitna size ka fibroid hai? What is the staging of the fibroid? Whether it is FIGO 0, FIGO 1, FIGO 2, and all that before we plan the surgery. So now this fibroid, even I will not attempt doing it hysteroscopically, although the report may come as a submucous fibroid. So then we should do a proper classification whenever we are dealing with a fibroid. The earlier definition was FIGO 0, 1 and 2, but the newer definition is also taking into consideration penetration, what is the location, what is the size, what is the extension of the base wall. So the size of the fibroid, the location, नीचे है या ऊपर है, lateral wall पे है, or it is at the fundus. So what is the size? How much is the base which is getting inside the? So all that should be taken into consideration before we go ahead for the and then we score it. So if you want, I'll share the scoring system. 0 to 4 I think can be done. Again, 4 to 5 is a high complexity surgery, and 5 to 7 hysteroscopic surgery is not advisable. Small submucous fibroids can be operated hysteroscopically. You can see over here. However, it is a good idea to check it with an office hysteroscope, even under anesthesia, and then you attach your resectoscope and then go ahead for the resectoscopy. Whenever we are doing a resectoscopy of a fibroid, always make sure the loop is under vision. Don't lose the sight of the loop at any point of time, and try and take the complete slices rather than leaving half slices in between. Sometimes, the traction goes away at half level. Then you take the whole scope and pull it down so that you complete the slicing, and then you go ahead. Now, this is a Bugatti shaver. Again, it is a hysteroscopic morcellator, or also called a tissue retrieval system. Expensive, but is a very, very good instrument to have. If you have it, it is excellent for the submucous fibroids and polyps. Sometimes it may be FIGO 2 fibroid. Now, there are many theories coming up. Again, Dr. Sandeep will agree with me that there is a very good study by one of the person from the ESGE, I'm forgetting his name, where he said that you just give a nick all around the fibroid and leave it, don't do anything, and then go back again. The fibroid from FIGO 2 will become FIGO 1 or FIGO 0, and then you can operate on the second sitting. Also, sometimes what we can do is here, as you can see what I have done, I have used a myoma screw. So we went all around. Patient sometimes want to do the IVF in the same sitting that they're visiting your country or your city. So you don't want to do a laparoscopic surgery. It's a very, very delicate myoma screw, 5 French. You can go in and then very gently, don't pull like in the laparoscopy because it will break. It is very gentle. All you can do is to make it from FIGO 2 to FIGO 1 or FIGO 0, and then we can use a resectoscope and do it. So I am not advising that we must all do the advanced hysteroscopy. It is just some videos that I'm showing that can be done, the hysteroscopic procedures. Now, again, when we talk about isthmocele is one thing. So whenever we are doing a hysteroscopy, you have looked at the fundus, mid cavity, and then isthmus. Isthmus pe you take the light source down and you can see if there is some endometrial tissue, some pouch-like thing, some vascularity there. Sometimes you may see a small polyp also sitting there. So that is the isthmocele, which can be corrected hysteroscopically, or depending on whether the patient wants more pregnancies. This is how it looks, isthmocele, which you probably could have already diagnosed on an ultrasound. And then suppose she has post-menstrual spotting. She doesn't want to conceive. She's only worried about that. And you are not able to resect it at that. जैसे resection शुरू करते हैं, the vision goes isthmus level पे. Then you can take a sharp curate facing towards the isthmus, and then do a nice curettage in that area. Go back again. Many a times you will see that small isthmoceles will have been they will get flattened just with the use of a sharp curate. So that also can be done in some cases. Again, sometimes, especially in patients with infertility, we can use, this is a bipolar hook, which can be used for lateral metroplasty. So we can do it as an office procedure. We can also plan it and do it as a procedure under anesthesia. So in some cases, again, very important is to select the patient. We should not be doing this metroplasty for every patient where we find the cavity small. T-shaped uterus, very clearly you can't see both the ostia in the same sitting, in the same view. That is when this particular procedure in selected group of patients can be done. We also did a publication on hysteroscopic installation of PRP. Sandhya was with me when we did this study, many months of study that we conducted, and then we started doing this intrauterine, the hysteroscopic PRP into the endomyometrial junction. We published this and we got good results in cases with thin endometrium. We injected at 4 places: anterior, posterior, right lateral, and left lateral. So when we were doing the study, we realized that this is an ovum pickup needle. So when we finished this 6th serration, there are 6 serrations on ovum pickup needle, and we were doing it under ultrasound guidance abdominally. Then that is when we were at the endomyometrial junction. So that is how we kind of standardized the whole technique, and this is indeed giving good results to the patients where nothing else is working in cases of thin endometrium in infertility patients. So there is so much to be done, so much we can show in hysteroscopy, but I don't want to take up the time for the next speaker. And thank you very much. And if there are any questions, then we can take it. This is how, I'm sorry, this is how the PRP is prepared. So if you want, anybody wants, I can share the preparation of PRP. Earlier, Sandhya, if you remember, we were using single 8 ml blood collection. Now, I actually went to Dubai and one first IVF center there, and there they are using this particular technique. And then we did a study on the platelet concentration, and we found the concentration of platelet and other growth factors is much high with this kind of preparation. So this is a specific way of preparing. This is how they are doing it there, and I copied it. I went to teach over there and I got something, learned something, came back. And this is how we are now using, preparing the PRP and using for hysteroscopic PRP. And also ovarian, you can use it in the same way. However, the ovarian PRP has not been very successful for most of the patients. So thank you very much. And if there are any questions, anything, we can take it. Thank you so much.
Thank you, ma'am. Thank you, Minu ma'am. That was very, very impressive and very lucid presentation. And indeed, you started from the very basic hysteroscopy and took us to the advanced level of hysteroscopy. And we really felt anybody can do it. But I know that's not very easy. It's a very long learning curve. And we all know that by repeated doing and practice, definitely one can master this art of hysteroscopy. The thing that I liked in your presentation is the practical tips that you gave us at each stage, right? That is the non-touch technique of entry, then the shape of the hysteroscope and the shape of the os that determines the entry, then why 30 degrees should be used, and why, how to go ahead and how to deal with the synechia, and that roof should be under view all the time. So all these very little, very small practical tips are indeed very helpful to us in our practice at the beginning. And of course, you also told us about the advanced procedures that we do with the help of resectoscope, and the important point that how to deal with the isthmoscope and the lateral metroplasty. So very, very impressive, very, very indeed, very interesting presentation you did here. Thank you so much, Meenu ma'am. Sandeep sir wants to say something.
Yeah, I would request Sandeep sir to give his expert comments, because he's also such a...
Sir, you're on mute. Yes.
Yeah, okay. It's a very wonderful talk, ma'am. And it was a delighted moment for all of us to watch beautiful videos of you. And I really think that you are a leader of hysteroscopy, and everyone wants you to be in the FOGSI as a leader. So I wish you all the best for your this VP elections, and hope next year and coming years you will be there as a Vice President of FOGSI.
Yes, ma'am.
Thank you.
Are all best wishes with you, ma'am. And
Thank you, Dr. Ruchita.
Yes, thank you so much.
So after an interesting session on hysteroscopy, now we move on to a topic which is close to all our hearts, as being obstetricians, basically. So the next topic is talk is on intrapartum care for joyful motherhood. And for that, I would call upon the next chairpersons. I would invite Dr. Sumitra Yadav, madam, and Dr. Shweta Kaul Jha, madam. Welcome, ma'am. So, Dr. Sumitra, madam, is at present, she is the president-elect Indore OBGYN Society. At present, she is also the VP of Vice President of Indore OBGYN Society. She is a professor and head of Department of Obstetrics and Gynecology at MGM Medical College and MTH Hospital, Indore. She has a teaching experience of almost 31 years. She's a TRG member and technical expert at NACO from 2008 till date. She was an organizing scientific chairperson and workshop coordinator at 65th AICOG 22, scientific chairperson for VP Conference October 23, and organizing secretary ISAR at National Conference, and organizing secretary AMPOJs. She has many awards and accolades to her name. To name a few: Nari Shakti Award by Braj Bhumi Foundation of Hema Malini on September 13, Nai Dunya Naika Award on Distinguished Social Service in 2012, and winner of Dr. C.S. Dawn Award twice for Best Paper Presentation in 2001 and 8, to just name a few. Welcome, ma'am. Now I request Dr. Amol Luthra, Medical Secretary, to please introduce our next chairperson, that is Dr. Shweta Kaul. Amol, sir. I would request Dr. Vaishali, ma'am.
Yes, Sandhya, sorry.
Yes.
So, it was a very nice lecture by Dr. Meenu madam, and now we move ahead to our next lecture. And the chairperson for our next lecture, Dr. Shweta Kaul Jha, madam, from Indore OBS-GYN Society. So, she is the...
Amol, we can't hear you.
Yeah, madam, you can hear?
Now we can hear him.
Actually, I was just operating, so the slide is not visible to me for introduction. Ma'am, you can see the slide?
Yes. So you do want...
Yes, Sandhya, please, if you can introduce.
Yes, I'll do that, sir. Thank you. So Dr. Shweta Kaul Jha, she is at present the General Secretary of Indore OBGYN Society and Director of Niramay Care Women's Center, Infertility and IVF Center, Indore, and she's life member of ISAR since 2012. She was a workshop convener for many conferences: ISAR 2016 Indore, STAR in Endogyne Conclave 2019, AICOG 2022 Indore, and ISAR Bhopal 23. Also, she is at present, as I said, Secretary of Indore OBGYN Society, Joint Secretary in 22-23, Managing Committee member from 2014, Executive Member MP ISAR 22-24, and Executive Member Women Doctors Wing IMA Indore 2018, member of FOXY committees, Adolescent Committee, Infertility Committee, Midlife Crisis Committee, Young Talent Promotion Committee, to name a few. And she has various awards and distinctions to her name. Dr. BNB Rao Gold Medal. She's the first board certified reproductive medicine specialist, FNB Reproductive Medicine of Madhya Pradesh, and also conferred the Dronacharya Award by ISAR, just to name a few. Welcome, ma'am. Welcome, Shweta, ma'am.
Thank you, Dr. Sandhya.
Yeah, I request Dr.
Can
Shweta.
I have the CV of Dr.
Yes. Yes.
Thank you, Dr. Meenu ma'am, for inviting us here. Thank you, Sandhya, for your kind words. I'd like to introduce the next speaker, which is the President, Indore Obs-Gyne Society, Dr. Sadhna Mehta madam. She is a gynecologist, senior gynecologist and obstetrician with 29 years of experience in dealing with high-risk pregnancy, infertility, laparoscopic surgery, and colposcopy. And she's running a multi-specialty hospital. And she has received award by Limca Book of Records for operating huge para-ovarian cysts, recipient of Wonder Foxian Award, received second prize for paper presentation at ISAR, and presented papers at national conferences and IMS Con, ISAR, IOGS, Foxy on topics related to recurrent pregnancy loss, one-day hysterectomy, and various other subjects. And she is a specialist at laparoscopic surgery, colposcopy, high-risk pregnancy, and infertility treatment. I welcome you, ma'am, today. Sadhna, ma'am. Unmute yourself.
Yeah. Good evening. Thank you, Shweta, for your kind words. I thank Dr. Meenu, Dr. Sandhya, and everyone from Pune, as well as from Nagpur Society, for inviting us and meeting all on a virtual platform. So today I'll speak on the management during labor. Thank you, everyone. I'll start sharing my screen. Okay. Evening, everyone. Yeah, today I'm going to speak about intrapartum care for joyful motherhood. So it's very important for an obstetrician to manage the labor efficiently and to manage a patient in delivery so that the patient doesn't get much of complications and the pain is also reduced. The patient gets patient delivers fast and we relieve her pain also, and we ensure adequate uterine contractions. We try and help each and every patient to have fast delivery, like we do active management of labor in most of our cases. And this is my practice since for so many years. I'm doing it and observing and managing my patients. So the goal of active management of labor is to prevent infection, dehydration, ketoacidosis, and as well as to reduce exhaustion of the mother and to reduce the incidence of fetal distress also. We use partogram so that all the events are being recorded, like maternal pulse, blood pressure, then cervical dilatation. On the partogram, we see how much is the dilatation. In a multi, it should be 1.5 centimeters per hour, and in a primi, it should be minimum 1 centimeter per hour. And we record the fetal hearts also, how much is the fetal heart, then the uterine contractions. Everything is recorded. We select the patient accordingly. We have done selection, like we use the patients in this study, the patients with no risk factors, like no risk factors of diabetes mellitus, no preeclampsia, IUGR, severe oligohydramnios. All these conditions are not included in this study. We should see that the patient has a full-term pregnancy from 37 to 41 weeks of pregnancy, and primi or maybe multi with cephalic presentation. We have not included breech presentation in such in this study, and we have not included cases of obstetric complications in this study. So on admission, the NST should be reactive, and the active phase of labor with cervical dilatation of 3 to 4 centimeter and effacement of 50% should be there. And then we do active management of labor. And as I told you, we have taken up patients with no obstetric as well as medical complications. So low-risk patients were taken up for this study, and we always keep the present anesthetist as well as the neonatologist should be present in this, where present, and the consent has to be taken from each and every patient. For whatever treatment we are giving, we should be counseling the attendants as well as the patient. During labor, we should explain them what we are going to do, how we are going to manage the delivery. So patients to be considered for intrapartum care, where such cases like polyhydramnios, oligo with CPD, malpresentation, with PPRAM, such patients were excluded from this study, and all patients who were with normal parameters were included. And patients in active labor were included in the study, and uterine contractions which come at a frequency of at least 3 or 4 per 10 minutes were taken up. And then in such conditions, the head should be engaged. Sometimes the head was not engaged. They were also taken up for the study. And there should be no clinical suspicion of CPD. This is also very important. And medications as per protocol used were the drugs which are used to provide effective pain relief. Labor analgesia were given coupled with antispasmodic drugs which help in cervical softening, dilatation. And the advantage of protocol is that this provides the benefit of drug synergism while at the same time restricting the drugs to minimal amounts, so that achieving the progressive labor. At the same time, the patient delivers very fast, and there are not much of complications, and we could avoid the incidence of cesarean also. We started with an intravenous infusion line with 5% finger lactate solution at a rate of about 20 to 30 drops per minute. We ensured that pains are optimal, like 3 to 4 sustained pains in 10 minutes. If necessary, you can add 2 units of oxytocin to the drip or give a tablet of Primifrost orally every hour to ensure optimum pains resulting in progressive dilatation. We can give for pain relief, we could dilute 1 ampule like 30 milligram of pentazocine like Port Vein with a diluent like distilled water or saline is diluted, and same way diluted in 10 ml of distilled water. Same way diazepam is also diluted in 10 ml of distilled water, and 1/5 of each drug is given IV through IV line. Then start an infusion like we are giving IV fluids. We are giving 2 units of oxytocin added in the drip in 500 ml of drip, and you keep on monitoring the fetal hearts. And you can also add a tablet of Primifrost orally every hour to ensure optimal pains resulting in progress of labor. So, like pentazocine, like I told you, that is given. Then observe the progress of labor by charting maternal and fetal parameters. So it should be done if the pains are very strong. You assess the fetal hearts, maybe by by electronic continuous monitoring, or maybe by fetal monitor. It should be done every 15 to 30 minutes, and assess the progress of labor on the basis of cervical dilatation and descent of fetal head, as documented periodically on partogram. When patient is in advanced labor and fetal head is pressing down on pelvis, and patient starts complaining of severe pain or bearing down sensation, at that time the cervix is almost 7 to 8 centimeters dilated. This is the time you can give, if needed, you can give ketamine if required, if the patient is not able to tolerate pains. If the patient, instead of giving Port Vein and Compose, we can also give Tramadol in the drip, or you can also use ketamine diluted. So the level of analgesia assessed during using following scale. If there was no pain relief, that is comes in category 0. If there is mild pain relief, it comes in grade 1. Then moderate pain relief in grade 2, and excellent pain relief in grade 3. So what the clinical evidence says, when we have used oxytocin as well as the analgesics, as well as in some of the cases we could use Primifrost tablets. In some of the cases we have used dinoprostone gel, supposing the patient is in 4 to 5 centimeters and still the pains are not very strong and the patient is not delivering, it is delayed, we could also use dinoprostone gel vaginally also. So in all such cases, the number of vaginal deliveries with low forceps assistance, ventouse assisted, where the maximum deliveries, the number of cesarean were reduced with this method. The mean duration of active phase of labor was also reduced to around 3.5 hours. Then mean rate of cervical dilatation and mean duration of second stage was also reduced. And pain relief was excellent in substantial group of patients. So this is something very interesting, very important. For a patient is relieved of pain and patient delivers very fast. So rate of cervical dilatation in active phase of labor, it was reduced to around 1.72 centimeters per hour. And duration of stages of labor, it's shown in the table. So pain relief was also maximal with this regime, and the complications in both the groups, like in control group as well as in the groups which were given these analgesics, the complication rate was also not much increased, like nausea, vomiting, drowsiness, tachycardia. They were minimal, and all these symptoms subsided after around 10 to 12 hours or maybe earlier. So results were fantastic with this, and the rate of cervical dilatation was also improved, and the duration of active phase of labor was also significantly reduced, and the duration of second stage of labor was 27.4 minutes in cases and 34 minutes in controls. That means it was reduced significantly. Majority of the patients in both the groups delivered vaginally, and in study group they had pain relief. Majority of such patients had pain relief as compared to 22% of control groups where pain relief was not much. The cases had significantly more drug-related side effects like nausea, vomiting, drowsiness, but then all this subsided after 12 hours. And so this is the plot of comparison. So antispasmodics, they reduce the duration of labor. We use epidocin injection like palithamide bromide is used, and it helps in cervical dilatation. So this chart shows how effectively we can use epidocin injection, and we can reduce the number of cesarean by using this protocol. So a single dose of 16 milligram, a prospective randomized controlled trial was done, which showed that a single dose of 16 milligram of palithamate bromide was administered by IV route in randomly selected nulliparous and 37 multiparous women. The median time from complete cervical dilatation to delivery was around 20 minutes. So it is very effective in helping the patient to deliver fast. This is very good in helping the patient to deliver in nulliparous as well as in multiparous patients. The distribution of the cases in terms of side effects of palithamate, side effects were not much, like there were minimal side effects of dry mouth, flushing, headache, and nausea and vomiting. But these were transient, and they these complications were not very serious, and it has given very good results. And therefore, we can say no statistical significance was found when adverse drug reactions were compared between the age groups of 18 to 25 years and 26 to 35 years. Therefore, adverse drug reactions reported were irrespective of the age of the patient, and number of life-threatening or severe forms of adverse drug reactions were seen with hyoscine and palithamide. No severe reactions were seen with hyoscine as well as palithamide during labor. So, rotavirine hydrochloride versus palithamide bromide for cervical dilatation in labor. A comparative study was done, and they've shown all these things, the cervical tear and all these things were very less. So advantages of shorter labor with using oxytocin as well as epidocin injection, shorter labors with sustained pain relief, significant amnesia of painful events of labor, and average blood loss was also less, and the duration of all the 3 stages of labor was markedly reduced. Obstetric management is simplified, thereby lowering the incidence of operative deliveries, and neonatal morbidity was similar to the control group. There was not much increased neonatal morbidity as well as mortality. So this helps the patient in reducing the number of cesarean, in reducing the pain during labor, in reducing the number of complications like dehydration, infection, and all these things are ketoacidosis also is avoided. So I thank you for patient listening. Thank you, thank you, Dr.
For being very concise and precise in your presentation of intrapartum care, although we know that this is a long-standing concept of painless labor, but it was very well explained, and how to make the drip, how to make the injection, 1/5 of it, and 1/5 to be given every time, how it should be started in the active phase of labor before. I have a query that supposing that the patient is not in the active phase of labor, from 0 to 3 centimeters, we know that a lot of patients create a lot of hue and cry that they have a lot of pain, because nowadays the pain threshold of patients has reduced. What do you do regarding that? Do you give anything for that?
We give antispasmodics to such patients because they have many times the patient gets false pains. The cervical dilatation is not much and they are in latent phase of labor. Therefore, we give this antispasmodics like rotavirin, sometimes like we give cyclopam, like drugs, so that they are relieved. Sometimes we do give paracetamol or maybe ibuprofen tablets also we give for the relief of pain, because patient is not going into active phase of labor.
Yeah. So this you have spoken very well. The cervix should be 3 centimeter dilated, and the effacement, if it is preferable, if it is more than 50%, and if not, the use of ethermide bromide. And for progress of labor, basically the labor is also shortened. From a long labor, we are shortening the labor also, so the patient doesn't have the thing for that of a long prolonged labor. So you use even misoprostol or even oxytocin to reduce it.
Many times we give 5 units of oxytocin in 500 ml of fingerlactate, and then if the pains are not increasing at the same rate, like if the patient is not progressing, we do give 5 units in 500 ml of fingerlactate, and we monitor the labor very closely so that the fetal distress is not there and the patient is not like the fetal problems are not faced later on.
The advantages of this for all to know are that there is a shorter duration of labor, substantial pain relief. If you compare the pain relief in the study group, it was about 86% compared to the control group, that was 22%. The length of labor was reduced, the amount of pain was reduced, and it also lowered number of operative deliveries. And the best part was that there was no neonatal damage or death in the study group, while there was one in the control group. It's a very nice thing. Dr. Sadhna Mehta, I salute you. Thank you very much.
Thank you. Thank you, Sumitra ma'am. Thank you. Thank you. And all the best to Dr. Meenu for your elections.
Yeah. Thank you, Sadhna Mehta ma'am. That was a fantastic talk. We really learned so much from you. It's best to hear from the expert like you. And that was excellent summing up, Sumitra Yadav ma'am. Thank you so much. It's indeed an honor to welcome such luminaries from Indore Society for this particular session. And thank you, Dr. Shweta, for chairing this session. I always come across you very sweet, bubbly, dynamic young leader, young General Secretary of Indore Society. So wonderful to have the dynamic leaders of Indore Society with us.
Thank you, the kind words for Indore Society. But I think Pune is an extension of Indore. I always feel that. Thank you very much.
Thank you so much.
Thank you. I would like to thank Dr. Meenu for this idea of collaboration. Thanks once again. And I want to thank Dr. Aarti and Dr. Meenakshi, the sitting president and secretary of Pune Society. I want to thank Dr. Vaishali, past chairperson, Neonatology Committee, FOXY, and Dr. Charu Bapai, chairperson, Female Breast Committee, and for giving me, and Dr. Amol Lunkar. The whole team I want to thank on behalf of IOGS for giving us this opportunity to collaborate with two wonderful societies and to give me a chance to be in companies of stalwarts like Dr. Lakshmi Srikhande Madam, Dr. Sonia Malik Madam, and Dr. Jyoti Banglowala. And Dr. Sandeep, Dr. Rujita, and our own Dr. Sadhna, Dr. Sumitra, and Sandhya did an excellent job. She called me and sometimes I couldn't receive also, but she responded well on the messaging.
Dr.
Thanks a
Sandhya
lot.
Mishram too. Dr. Sandhya
Yes,
Mishram.
Dr. Sandhya Mishram. Yeah.
Thank you. Thank you.
Thank you. Thank you, Dr. Vishali.
Sandhya? So we would like to propose a vote of thanks. First of all, we are truly indebted and we would like to extend our deep gratitude to Indore OBGY Society and to Nagpur OBGY Society for being with us, and to all the delegates who have logged in today and listened to this wonderful talks by two great speakers, Dr. Meenu Agarwal and Mehta Madam, who gave excellent talks because they are indeed experts in the field. And thank you to Pune own parent society, POGS Pune OBGY Society, Dr. Aarti Nimkar, President POGS, Dr. Meenakshi Deshpande, Dr. Amol Lunkar, Dr. Meenu Agarwal, Dr. Charu Bapai, who is not today with us because she's busy with the family matter. And thank you especially for Chief Guest, Dr. Lakshmi Srikhande, Dr. Sonia Malik, Guest of Honor, Dr. Jyoti Banglowala, Guest of Honor, Nagpur Society President, Dr. Sandeep Nikhade, Dr. Rujita Phuke, General Secretary, Indore President, Dr. Sadhna Mehta Ma'am, Vice President and President-elect, Dr. Sumitra Yadav, and Dr. Shweta Kaul. And a special thank you to our young Dr. Sandhya Mishram, who is absolutely very focused, very diligent and sincere young IVF consultant. So it has been a great honor, great pleasure to connect with all of you, and truly, truly honored from very, I would like to express deepest sense of gratitude. So thank you to all of you. And thank you, Mr. Prasad, and thank you, BSV, for enabling this wonderful academic session.
Thank you, ma'am. Thank you.
Thank you all.
Thank you, Sandhya. It was
Thank
nice connecting to you and Dr. Rujita. Rest I have
Thank
been
you.
missing.
Thank you, Aarti ma'am. Thank you, Meenakshi ma'am. Thank you, Meenu ma'am.
It was
Thank
really
you,
nice.
Vaishali ma'am.
Yeah, looking forward to again catch up somewhere.
Yes,
It was really nice. Nice to
Thank you, Shweta ma'am.
Yeah.
Thank
Best
Thank
of luck, Meenu ma'am. All the best. Okay. Thank you, everybody.
Thank
Bye.
you. Thank you,
Bye-bye.
everyone.
Thank you, ma'am.
Have a good day.
Milan, stop recording.
Recording stopped.